Hello, everyone. My name is Gurjot Basra, and I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada. I'm very pleased to welcome you all to this breakout session on diffuse large B-cell lymphoma. Just before we start, as usual, I do want to go through a few housekeeping items. So this Zoom software does not allow you to access chat features or turn on your microphone. So if you have a question, this session will be followed up by a live Q&A session. So please keep your questions in mind and be sure to attend the diffuse large B-cell lymphoma Q&A afterwards. So to introduce our speaker, today we have joining us Dr. Anka Prika, who is a staff hematologist at Princess Margaret Cancer Centre, an associate professor in the Division of Hematology at the University of Toronto. She did her initial medical training in Toronto and her clinical training in internal medicine and hematology at the University of Toronto program. She then did a 2-year fellowship in malignant hematology and a master's in health research methodology at McMaster, with research interests in quality of life and economic evaluations. Her clinical work focuses on both lymphoproliferative and plasma cell disorders, as well as autologous stem cell transplantation and CAR T therapy. So thank you, Dr. Prika, for joining us today, and you can get started as soon as you're ready.
Great. Thank you so much for having me today and for that great introduction. And today I'm going to go through some details relating to diagnosis and particularly treatment and new treatments for diffuse large B-cell lymphoma. Just some disclosures. I have received some consulting fees from a couple of companies that make drugs that treat lymphoma, including CAR T-cell therapy, and those are the two there. And that's mostly some meetings where some of these drugs get discussed. So the objectives today will be to broadly review how to diagnose diffuse large B-cell lymphoma and some features related to its to the risks of responding or not responding to therapy, and to understand new therapies in DLBCL and how they are used. And when we have the Q&A session afterwards or later on to answer your questions. So first of all, just a brief review of where do lymphomas arise from. So it's largely from the lymphatic system, which is a network made up of lymph nodes, lymphatic vessels, and includes some organs as well, like the bone marrow, the thymus gland, which is in our neck, which presents lymphocytes up to early adulthood, tonsils, the spleen, the liver, and even in lining of things like our gut, our lungs, and other areas. So what are lymphomas? These are cancers that develop from the cells of the immune system. Largely, we think of them involving the lymph nodes and as well as the spleen or the bone marrow. But as I showed you in the previous slide, lymphomas really can arise anywhere because we have lymph nodes and lymph cells all over our body. And can also have a leukemic phase, which means leukemic just means that the cancer cells are in the blood. So though sometimes that word invokes a thought of different blood cancers like acute leukemia, there can be more chronic lymphoma type processes where there are lymphoma cells in the blood. Lymphoma in general is the fifth most common cancer in Canada, and the incidence has been increasing over the decades. And there are approximately 9,000 new cases per year, most of which are under the non-Hodgkin lymphoma category, which is what we'll be talking about today, diffuse large B-cell lymphoma being a subtype of non-Hodgkin lymphoma, and a smaller proportion is a different category, Hodgkin lymphoma. So just to put it into context, when we think about lymphomas, again, we can divide them as non-Hodgkin and Hodgkin. The majority of cases are under the non-Hodgkin lymphoma category, and about 80% of those are B-cell lymphomas, arising from, we have B cells and T cells in our body. The most common are B-cell lymphomas, and then we think of them as aggressive or indolent or slow growing. And you can see on the left here that diffuse large B-cell lymphoma will be categorized under the aggressive subtype, which really just means how it looks under the microscope, how large are the cells and how quickly they're growing. And then a smaller proportion of lymphomas are T-cell lymphomas that arise from a different lymphocyte. Diffuse large B-cell lymphoma is the most common type of non-Hodgkin lymphoma and makes up about 25% of all non-Hodgkin lymphomas. Before we get in a bit more into details about DLBCL, just a little bit of review of how to diagnose lymphomas, and very important to have a good amount of tissue from whichever area might be involved, usually that either with a biopsy involving a kind of a larger needle, or more rarer these days, having a whole lymph node or a whole area surgically resected. Because as I've shown you, there are numerous different subtypes, and they can be patchy throughout the lymph node in terms of their involvement. We really want to make sure that we have the right diagnosis, and for that, we need a good amount of tissue. And sometimes the biopsy can look suspicious but not conclusive, and your doctor may say that it's necessary to have another biopsy, which can feel stressful in terms of delaying the diagnosis, but it's very important for making sure we're treating the right disease. Sometimes it can be from a bone marrow test, which is the part in our bones that makes blood cells, and more rarely from the peripheral blood, usually with more indolent type lymphomas and leukemias. And then once a diagnosis is confirmed, we want to know where it is in the body by staging it. And again, because lymphomas and lymphocytes can be throughout the body, it's not uncommon for numerous areas to be involved. But most often, these cancers are still very treatable, even if they're more advanced stage. But the staging is largely, sometimes still a little bit through physical examination, if we can feel the lymph nodes, but often more through imaging with CAT scans of the neck, chest, and abdomen area, but also very standardly now with something called a PET scan, which is like a CAT scan, but it adds a sugar type solution that lights up where the lymphoma might be, so it's a more accurate, adds some accuracy to the staging. So both of those, the PET scan and the CAT scans, are done together to really confirm the staging. And a PET scan would be done at diagnosis, but then as well at the end of therapy and sometimes partway through to look at the accurately at the response to treatment. And when we think about staging for lymphoma, there are 4 stages, and you can see here if that one area is involved, like some lymph nodes in the neck, that would be a stage 1. Stage 2 is having more than one area, but it's all either all above or all below the diaphragm. So the diaphragm is the separating anatomical area for having more advanced disease. Stage 3 would be where there's lymph nodes or the spleen is involved throughout the body. And then if organs are involved, like the liver or the bone marrow, that would be stage 4. But still important to say that even, especially with diffuse large B-cell lymphoma, which is an aggressive lymphoma, if people have more advanced stage, it's still a very treatable and often curable problem, which is different than perhaps some other solid tumors that we may know about. So moving on now to more specifically talk about diffuse large B-cell lymphoma, which, as I mentioned, is an aggressive B-cell lymphoma. It's the most common aggressive lymphoma and about 240 patients are diagnosed, for example, in the Toronto area per year. The median age, or sort of the average age when patients are diagnosed, is about 60. When people are diagnosed, it's about 65 years of age, but it can range from quite young people in their 20s to people in their 80s and 90s. About a third of the patients of the time, the disease is localized to that stage 1 or 2 I had highlighted before, and about 60 to 70% have advanced disease. And the standard treatment, which I'll talk in more detail, slides coming up, really is a chemotherapy, CHOP chemotherapy, with the addition of immunotherapy, rituximab, these are given intravenously every 3 weeks for 6 treatments. And this has been the standard treatment for over 20 years. And despite numerous attempts to improve on it in the past by adding different therapies or giving more intensive chemotherapy, have not shown that we can improve outcomes over this recipe. And with this treatment, the diffuse large B-cell lymphoma is curable in about 60 to 70% of patients, meaning that in that amount of patients with just this treatment, we are able to get rid of the lymphoma and not have it come back over time. There are some ways that we can, at the beginning, tell what the likelihood of responding to therapy might be, or if it's a little bit less than what I showed, the 60 to 70%, or a little bit more. So these are some risk factors. So one way of looking at clinical features is through the International Prognostic Index, or the IPI, and includes 5 easily available variables like age, the stage we talked about, performance status, so what is the impact of the lymphoma or other medical problems on the daily life, how sick are you, or how sick someone is, the number of extranodal sites, which means areas that are not the lymph nodes, and then a blood test called lactate dehydrogenase, or the LDH level. There's been some adjustments to this where it can be age adjusted, or different ways of better understanding this index, but it's still, depending on how many of these variables someone has, gives us a bit of a sense of how likely they are to do well with a treatment. There are some other ways of looking at diffuse large B-cell lymphoma, more from the actual cells and the pathology, that might also give us some indication of the risks of not doing as well as we were hoping. There are ways of looking at the genetic patterns through molecular features, is a term used. And this is not, these are not genes or genetic changes that are hereditary, so it's not something that's passed down from parents to kids. It's more just genetic changes in the cancer cells. And there's 2 different patterns that have been well described that give us some different information, something called germinal center B-cell-like and activated B-cell-like, GCB or ABC. And that is a term that you may hear about or read about, or your doctor may talk to you about. There's also some different ways of that protein is expressed in the cells, something called c-Myc, which turns on a lot of genes and makes cells grow, something called BCL2, stops cells from dying. So when both of these proteins are expressed on the cells, when the pathologist looks under the microscope, it might be described that the lymphoma is a dual expressor lymphoma. And there can be a bit more specific chromosome or genetic changes, again, in the cancer cells, not hereditary, where there are breaks in the chromosomes or translocations involving these genes, the c-Myc and the BCL2 genes. And when there are these changes in both of these genes, the lymphoma is described as having a double hit, so having had hits in both of these genes, and that's a more aggressive lymphoma that's more difficult to treat. So to kind of re-summarize what I described above and what the outcomes might be according to the genetic changes, if we think of those 2 descriptions, the GCB and ABC, generally the GCB subtype has a better outcome than the ABC subtype. Having neither of the c-Myc or BCL2 have the best outcomes, having the dual protein expression, so the cells expressing the c-Myc and BCL2, which is about 20 to about a third of DLBCL patients, is a little bit less good. And having the double hit lymphoma, which is 5 to 7% of DLBCL, is generally a poor prognosis, at least with the chemotherapies we have. And there's work ongoing with newer therapies that I'll talk about to see if they would be better treated with these newer treatments. So the current-ish standard, I would say, although it is somewhat in transition, and again, the standard that we've had for many years for frontline treatment or the first-line treatment when someone first presents with this diagnosis, is giving 4 to 6 cycles of this R-CHOP chemotherapy, so rituximab, plus 3 different intravenous drugs. and completing after that amount of cycles. For the double hit lymphoma, occasionally we consider a little bit of a more intensive chemotherapy regimen that's more of an infusion over a few days, and that's something called dose-adjusted R-EPOCH. Very similar concept of several chemotherapy drugs and rituximab, but just given over a few days. And occasionally at the end of chemotherapy, there may be a consideration of radiation. And if that all goes well and the lymphoma goes into remission, people are usually followed every 3 months for a couple of years with mostly clinical examination, seeing how they're doing, and then it spreads out over the following few years. And on the most part, if the lymphoma hasn't come back after 5 years, we think the risk of it coming back is very low, close to zero. And there's a discussion of potentially going back to your family physician for ongoing follow-up as considered cured. What about, if it doesn't, this is just a little bit of an algorithm showing until about 2024, so about a year ago, what the pathway would have been if the lymphoma didn't do as well as we had hoped and does come back after the frontline therapy. The general second line approach was to think about whether someone is eligible for an intervention called autologous stem cell transplant, which is essentially giving high doses of chemotherapy to try to better kill the lymphoma, and then using a patient's own stem cells to support that, to give them back and grow back the healthy cells. Eligibility really is based on how well someone is, do they have other comorbidities like heart or lungs, what their function is like. We don't have a strict age cutoff, but as people get over the age of about 70, the toxicity versus the potential for help is something we have to balance. If someone was not transplant eligible, there are a number of chemotherapies that could be considered, including a recipe involving a drug called polatuzumab that I'll talk about, but generally not as good options as we'd like. And if the lymphoma came back after the second line of treatment, over time we've thought as the outcomes being quite poor. However, newer therapies like CAR T-cell therapy that I'll talk about and other treatment have improved some of those outcomes, and those have been around since about 2019. So with that in mind, I'd like to move on to talk about some of these newer treatments for DLBCL in the last sort of 5 to 6 years plus that have really changed the landscape of lymphoma, of DLBCL, which was largely treated with chemotherapy and radiation in the past. And after trying that a couple of times, often we wouldn't really have other good options to try. Before I speak about some of the treatments and the data and the studies that have brought them to the forefront, I just wanted to talk a little bit about clinical trials as a background in terms of how drugs get developed. As sometimes a patient may be offered a clinical trial to participate in, and there are different phases, we call them. So a phase 1 clinical trial is really the kind of the first time that a new drug is being tested in humans that seems promising in the laboratory testing. And the study is really trying to understand how much can be given, what are the side effects, do some correlative, some extra studies on it to better understand how it's working. Does treatment do in people what it did in the laboratory and animal models? And the result of such a study is the recommended dose and schedule to test further. Next would be a phase 2 clinical trial, and the question in these trials are often, does this treatment work? So it's testing the drug in a larger number of patients, usually not hundreds and hundreds, but more in the perhaps 50 to 100 range, trying to understand what is the response rate to the new drug, and what are the side effects in a larger number of patients, an opportunity to, again, do some further studies to see, can we predict which population or subtype responds best? And how do we use phase 2 trial information? It's sometimes can be to adopt as a new treatment. It's an opportunity to say it is working well. Let's add it to a standard treatment or compare the new treatment to standard of care. Do phase 2 trials change practice? Only sometimes. As often there's still a need or desire to test them in then an even larger patient population. So that's where phase 3 clinical trials come in, which is really most often the type of study that changes practice or makes a drug the new standard of care. And this is really where we want to compare the standard of care to something new that is potentially better or has less toxicity. And this is the kind of data that often regulatory bodies like Health Canada, which reviews and allows drugs to be felt to be safe and efficacious enough to be available to Canadian patients. And this is the kind of data they're often looking for. And we feel that this kind of a larger trial is really necessary to determine if the standard of care should change. It is a randomized trial often, so participants don't choose which treatment they receive. Half the patients get the standard therapy and half the patients get the new therapy because we really want to know that it is better and not more toxic. And there's many examples of how these kind of trials have changed practice over time in lymphoma. When does a new treatment become standard? Usually requires a randomized phase 3 trial, as I've mentioned, that shows significant improvement in an important measure like survival, time to progression, or reduced toxicity. Sometimes phase 2 trials, which are non-comparative, so not really having another arm, but we can compare to previous results, can change study. And an example would be actually CAR T cell therapy following relapse post-autologous stem cell transplant in DLBCL. And this was approved and funded in Canada based on a phase 2 study because there weren't really good options afterwards, as I mentioned, and this looked much more promising than anything else that was available. And in Canada, because this often comes up in terms of what it takes for a drug to be funded and approved in provinces for patients to be able to access them. There's first the Health Canada approval, which is the drug company submits to them, and that is a process. But also there's a process in Canada where an agency called Canada's Drug Agency then reviews the drug for efficacy and kind of how well it works and how expensive it is, and makes a recommendation to the provinces whether it should be funded and whether price negotiations are needed to try to, because it is really, a lot of these drugs are very expensive. Then there's provincial evaluation by the cancer agencies for costs and feasibility. And finally, regional cancer center implementation. So it does take some time to get to that, but it ensures that that the drugs that are available with our publicly funded system are drugs that will really help patients. So moving on, so now that we have that background of kind of how some of these treatments move towards being available for use in standard of care, what are some of the newer treatments in lymphoma? And there are really many evolving therapeutic options involving immunotherapy in lymphoma. And on kind of at the top right here, you can see something called monoclonal antibodies, which is what rituximab is. So antibodies are proteins that our immune system makes, and we can manufacture them to bind to markers on the lymphoma cell to help kill the cell. And in this case, it's the CD20 marker. There are drugs called antibody drug conjugates, or ADC, and the one in lymphoma is polatuzumab vedotin, and I'll talk about that more in a minute. There are bispecific antibodies, or T-cell, or another category being T-cell engaging, like mosunetuzumab, epcoritamab, or glofitamab, which bring the immune system cells to the lymphoma cells to help kill the lymphoma better, and then CAR T cell therapy, which is really enhancing our own T cells or patients' own T cells to better fight the lymphoma. And I'll go through all these in a little bit more detail and where we are with availability of these treatments in Canada. So the first one is polatuzumab vedotin, which again, as I mentioned, is a category of drugs called antibody-drug conjugates, and this targets a marker on the lymphoma cells called CD79B. It's expressed on a lot of DLBCL cells, and essentially what it is a man-made antibody has a little bit of chemotherapy attached to it, and then it binds to this marker on the outside of the lymphoma cells and essentially injects the chemotherapy directly into the cancer cell. So I like to still think of it as chemotherapy is just very directed. So instead of giving intravenous chemotherapy that goes throughout the body and kills good cells and some bad cells, and a lot of our other cells kind of ubiquitously, this goes right to the cancer cell and again injects the chemotherapy in and leads to the death of the cancer cell. There are some, these markers sometimes are expressed on other organs in the body, and that's where sometimes some of the side effects can occur. And in the case of this particular drug, one of the side effects can be having neuropathy or some nerve type pain, and that's because this kind of more directed chemotherapy approach can affect the nerves in the body. So this drug was combined with some chemotherapies, including a version of that CHOP chemotherapy I talked about as our standard of care for DLBCL patients, and was shown to have quite good activity. Patients had good responses, and they were lasting. So it's moved to being developed further in combination with other chemotherapies. And it was first tested in this was actually a randomized phase 2 trial. So as I mentioned, there was a comparison to another standard treatment, but in a medium amount of patients. And this was tested in patients whose lymphoma came back after at least one prior therapy, and they weren't eligible for things like the autologous stem cell transplant, or they had progressed afterwards. And the study compared adding polatuzumab to a drug called bendamustine, which has activity in large B-cell lymphoma, and rituximab, the immunotherapy. And when it was compared to just bendamustine and rituximab alone, it improved significantly the chance of the lymphoma coming back and of people dying, or people's lived longer when they had the combination of the three drugs. And if you see here on the right, these are curves that show us over time how many people are still staying, whose lymphoma hasn't come back or are still alive. If 100% of people were still in remission, for example, that line would be flat up there at the 100% or the 1 at the top. So you can see with just BR, many patients do have lymphoma coming back, but adding the polatuzumab, the curve separated quite a bit, showing that the combination is better and people live longer. So this kind of data led to approval and funding of this combination in most provinces and in Canada, and that's been for about 5 or 6 years, and it is a regimen that's being used quite frequently. So when something works well in the second line or in in lymphomas that have come back, that drug can be considered for doing a trial in the front line to see if it could be better than our current standard. So polatuzumab was added to a sort of a version of the R-CHOP chemotherapy. So polatuzumab R-CHP, it's called. There's one drug, vincristine, which causes some nerve damage as well, that was replaced by the polatuzumab in this study. So this was a phase 3 randomized trial. So sort of a large trial to see is this new recipe better than what we had before. And patients got 6 cycles of each and a little bit of rituximab at the end. And this was a study that was done throughout the world. And it did show some improvement. So there was a chance. So when we look at the outcome of progression-free survival, which largely refers to the chance of lymphoma coming back over time, the combination, so the green line is the new therapy, the Pola-R-CHP, did a little bit better than the R-CHOP. So at 2 years, about 6% more patients remained in remission versus R-CHOP, which is some improvement, but perhaps we were hoping for something larger to really make a difference in changing the outcomes of these patients. And there was no difference in how long people lived with using these two recipes, which often is because there may be good other treatments in the second line setting that would be useful, that can work well. So still some improvement, but at least in Canada and other places, it was perhaps felt that it wasn't a good enough improvement to really change the standard of care. However, we are trying to, through these studies, to understand, are there some subtypes that might do better with some of these newer therapies, where it's worth giving the new treatment that might have a little bit more toxicity or other side effects. And with this study, it was actually shown that the ABC type, so if you recall, when we talked about different ways of categorizing DLBCL, there was the germinal center B-cell-like and activated B-cell-like, again, these molecular or gene patterns that differentiate different types of DLBCL. And these are things that can be, and there's a way to try to test for that. And if people have the ABC subtype, the addition of the polatuzumab, which is, it's under in the red circle here, the kind of yellow beige line, was quite on top of the just R-CHOP line. So at 2 years, the chance of being in remission was 85% versus 56% with just R-CHOP, so almost 30% difference. So really seems that in this subtype, polatuzumab is really improving outcomes, versus in the middle, the GCB type, perhaps not as much, not really a big difference between the two. So because of this data, this drug has been re-evaluated through that process I mentioned before, and how we evaluate drugs in Canada, and has been recommended for funding in the ABC, or that version of the subtype of DLBCL in Canada, and is something that certainly if you were considering treatment, or that was something that could be discussed with your doctor about whether you have this subtype and whether having this combination would make sense. And hopefully this will be available soon. It's still kind of going through the negotiation and implementation phase, but this will likely be a recipe that'll be available at least for the subtype, where we can tell that it's making a difference. The other therapy that's really changed the treatment or the outcomes of patients with the DLBCL is the CD19 CAR T-cell therapy. And really what this is we know that our immune system, our T cells, which are part of our immune system that fight foreign things, should know that cancer is bad and try to really kill it and get rid of it. And why don't T cells in our immune system do that? It's because lymphomas and other cancers are very good at hiding from our immune system, or exhausting it in different ways. So it's not as efficient at doing what perhaps it's supposed to do. So CAR T-cell therapy really takes these T cells out. So the T cells are collected from the patient, and they're manufactured or changed to better target the lymphoma. So in the cancer, in the lymphoma case, it's against this other marker called CD19 that's on lymphoma cells. So a patient's immune cells have these proteins or receptors kind of inserted into the cell to better recognize the lymphoma. And then they're infused back into the person, and ideally they grow quite exponentially and really significantly go on to fight the lymphoma. And you can see here then it goes on to really kill the tumor cells. And this here just demonstrates the process of this, where it's collecting the T cells. They go on to be re-engineered or remanufactured, infused back into the patient, and then they ideally proliferate quite significantly and kill cancer and lymphoma. There are some unique CAR T related toxicities, and the ones that I'll highlight is something called cytokine release syndrome and some neurological toxicity. Cytokine release syndrome is really, some definitions are a disorder where people have fever, shortness of breath, some headaches, some high heart rate, and it's really a supraphysiologic response following immune therapy that results in activation of sort of these of the immune system cells that have been infused, and it's kind of a significant inflammation from that. This usually occurs, so the red curve, if we look on the bottom, it's from the time the CAR T cells get infused over sort of the first week. Patients can have this cytokine release syndrome, and then there is the neurological toxicity risk, which I'll talk about in a bit next, which can occur a little bit later. Now there's a grading, so kind of how serious or severe this can be. And for most people, it's what's called grade 1. So it may be just fevers and feeling a little bit unwell. Grade 2 would be there might be low blood pressure, a little bit of trouble breathing, and these can be treated quite well with some drugs, like a drug called tocilizumab, or steroid medication, sometimes fluids and Tylenol. More rarely, it's more severe, where a person would have to go to something like the intensive care unit to be more closely monitored. And then the other toxicity we talk about is something called ICANS, which is a bit of a neurotoxicity where there's the CAR T cells go in the fluid around the brain and can cause some confusion, changes in speech, orientation, handwriting, concentration. And because of that, people are tested regularly through the day in terms of how their thinking is still going on this point scale. But again, it is having more severe neurotoxicity, or ICANS would be rare. For most, it's fairly mild, that can be distressing in terms of changes in thinking, but usually gets better over a couple of days, and with something like steroid medication. So in summary, there are unique toxicity to CAR T cells. Early on would be the CRS and the ICANS and other common things like fever and infection, the need for blood transfusions. But there are some late effects as well, such as having low blood counts that can continue for several months, so there's need for ongoing support. There is a risk of infection because the immune system is low after this treatment, and there is a small risk of getting other cancers, including other blood cancers. So because of this, after having this therapy, we need to monitor people regularly, actually probably for their lifetime at this point, even if it's just once a year in a specialized center, even if having ongoing follow-up with a local hematologist. So but now going on to kind of how have these changed practice, or where is CAR T cell therapy in the line of therapies. So I won't go through too much of the data in the third line setting, which was after where it's been available when people have had a couple lines of therapy. And in the third line setting, it can be curative in about a third of patients, but now it has moved to the second line setting. So we've had a series of trials, particularly and actually I should say there are 3 products from different companies that work a little bit differently, but the concept is about the same. A drug called Axicell, a drug called Lysocell, and a drug called Tisacell are these products. And these have been studied now in the second-line setting, so after patients have had frontline therapy, but their lymphoma didn't respond or progressed within a year of finishing frontline chemotherapy, so kind of a higher risk situation. And when comparing to the standard of care before, which was largely trying to get to an autologous stem cell transplant, we can see that the curves which are on top, the blue lines in Axicell and Lysocell, these 2 products demonstrate a significant improvement in the chance of putting the lymphoma in remission. And with the Tisacell product in the second line, unfortunately, didn't look as good, so that this isn't presently funded, but the other 2, Axicell and Lysocell, are funded in Canada for the second line indication. And they've also shown improvement in overall survival in the ZUMA-7 trial. So patients who had CAR T rather than stem cell transplant lived longer, which is one of the main outcomes we are looking for. We want to make people live longer with these treatments. And they are a little bit different, and I'm mostly highlighting the Axicell and Lysocell in terms of their toxicity. So if you look at the bottom here, the grade 3 CRS and neurotoxicity, those were the 2 more serious effects I talked about. They're a little bit higher, so 6% and 21% with Axicell versus 1% and 4% with Lysocell. So Lysocell has less toxicity, but it's been around for less time. We've only had it approved for a few months, whereas Axicell we've had for 1 or 2 years for this indication, and there's some different timelines and reasons why we would choose one over the other, and that's something that would be discussed if this was a treatment for you. So again, what is CD19 CAR T in DLBCL? Axicell, Lysocell, and Tisacell are funded for eligible patients in the third line plus setting after having at least 2 other lines of systemic therapy. And Axicell and Lysocell are funded in second line for patients whose DLBCL comes back within a year of finishing frontline treatment who are transplant eligible. And there are some, that would be a definition, or if that was what's the appropriate definition for that, it would be discussed with your doctor. And what is next for CAR T-cell therapy? Well, a lot of, or some of the work is trying to move it up front for patients that have really high-risk disease, like the double hit I talked about, or having a really high IPI score, those variables at the beginning. And one of the trials that's actually available at our center at Princess Margaret is the ZUMA-23 trial, which compared having the usual chemotherapy, R-CHOP or R-EPOCH, to Axicell, to CAR T-cell therapy for really high-risk patients. And it'll be interesting to see the results of this study. And then the final kind of newer therapy to talk about are bispecific antibodies. And how do these work? It's kind of a smaller version, I suppose, of CAR T-cell therapy, where this protein antibody brings together the tumor cell with those T cells that should be killing it, and it just brings them in closer proximity, so they have a better chance of killing the cancer. And in lymphoma, these drugs target CD3, which is a target on the T cell, and CD20, which is a target on the lymphoma cells, and again, brings them together so that the T cell can kill the tumor better. There are a number of current CD20 bispecific antibodies approved and undergoing testing in lymphoma. And these are some of the names: mosunetuzumab, glofitamab, epcoritamab, and odronextamab. Mostly glofitamab and epcoritamab are drugs that have been approved and are available for patients in Canada. Some of these other 2 are still undergoing testing and may be available in the future. Just to highlight a little bit of the data of bispecific antibodies, glofitamab was studied again in patients who had at least a couple lines of therapy, which usually we would think have fairly lower chances of doing well, even post, this was even tested in people who are post-CAR T-cell therapy. There's smaller, but their risk of having those CRS side effects. And because of that, it's given sort of in a step-up dose, and you get a small dose first, a medium dose, and then a fuller dose. And there's monitoring that's needed during that first part. But patients had good responses, including 40% of patients had complete responses, including those who had had CAR T-cell therapy. So very promising treatment. As I mentioned, there is a little bit of a chance of having the CRS side effect, but most of it was grade 1, so having a fever, and usually just within the first or 2 doses. So a little bit of work to get it started, but afterwards very well tolerated. And patients, those who respond, have durable responses. So when we see a flat line like that, means that those who are responding stay in remission, but then some do not respond at all. So again, this has been moved up to the second-line setting to compare adding glofitamab to a chemotherapy backbone, in this case, our GEMOX. And these are in transplant-ineligible patients, so those that we generally think might not go to CAR T-cell therapy in second line. And adding glofitamab to chemotherapy improved overall survival. Again, you see the green curve on top of the blue curve, as well as progression-free survival, so the chance of recurrence of lymphoma over time. And it was fairly well tolerated. Again, a little bit more of those some of the CRS and infections, and that's something to consider when considering this treatment for someone. So what's the status of bispecifics in Canada? Glofitamab and epcoritamab, I didn't go too much through that data, but it's very similar, are funded in the third-line plus setting, so available to patients. And because they require a little bit more of that monitoring and some specialized treatment. Not all centers are quite set up, for example, in our area to give it, but most are. Otherwise, they would find another center nearby that would be able to administer it. Glofitamab GEMOX, that addition of it to chemotherapy, will be evaluated for funding for second-line setting shortly in Canada. And there's also other recent data presented at conferences and published in the last 6 months, I would say, that demonstrated adding polatuzumab to GEMOX improved the chance of lymphoma progressing over time. So that may be an option in the future. And same for combining the polatuzumab, that antibody drug conjugate, with a BiTE, mosunetuzumab. So this combination was better than chemotherapy. And these will likely be evaluated for funding in Canada in the near future for that second-line setting for someone that's not maybe being considered for CAR T-cell therapy, and there would be these different options that would be discussed with the patient if appropriate for lymphoma that may have come back. And similar to CAR T-cell therapy, there are trials adding bispecifics to R-CHOP and Pola-R-CHP in the frontline setting, and some of them have been completed, and hopefully we will soon see results to see if that's something that will again change that frontline standard of care that we've had for over 20 years. So in conclusion, I went through quite a bit of data, but there are different factors that determine the chances of the DLBCL not coming back after frontline therapy that would be evaluated at diagnosis. There are many new therapies available and being studied for DLBCL that have really changed outcomes over the years, and they are available in all lines of therapy, and new indications are coming. Thank you very much. I think I'll stop there.
Thank you, Dr. Parikh, for that very informative presentation. I will now like to direct the audience to attend the Diffuse Large B-Cell Lymphoma Q&A to have your questions addressed. It will be starting shortly, so please make your way. Thank you.